So I would say in the last 10 to 15 years, there has been a revolution in understanding the pathogenesis of AML. And we have learned a lot about the variety of mutations that exist in AML. And these mutations can have a certain significance. One aspect of it could be that they are targets for treatment, such as FLT3 mutations or IDH mutations, or they could have certain predictive potential. So certain mutations may suggest an increased likelihood of response. For example, there's been some recent data that suggests that those individuals with p53 mutations may respond better to hypomethylating agents. Or they could have prognostic implications. For example, FLT3 mutations are thought to have a worse prognosis because of their increased propensity for relapse. Similarly speaking, I would say p53 mutations have a worse prognosis in general because they tend to respond less to treatment and also have a worse long-term outcome as a result. As far as targeted therapy, part of this evolution or revolution in finding mutations in AML is that we could perhaps find drugs that target them and isolate patient populations that may benefit from these new targeted therapies. So FLT3 inhibitors now, there is a series of them that have undergone clinical investigation or are currently present. The first generation of FLT3 inhibitors were relatively non-specific. Nevertheless, one of them has recently gone through phase 3 clinical trials in combination with induction chemotherapy, midostaurin, and is now approved for use in patients who are FLT3 mutated and are eligible for induction chemotherapy. So those patients, generally speaking, receive induction plus midostaurin in the hopes of getting into a remission and then going on to consolidative treatment such as bone marrow transplant. There are several other more potent and specific FLT3 inhibitors that are currently under investigation. They are much more selective than midostaurin, likely much more potent, and they're being studied initially at least as monotherapy, but in time also in combination. So we will see how the paradigm will shift across the board for FLT3 mutant patients. As of now, the recommendation is that those individuals who are newly diagnosed and are eligible for induction chemotherapy should receive induction chemotherapy plus midostaurin. Down the road, if there are other FLT3 inhibitors that become approved and are available for use, we may be using these drugs for patients who are relapsed and refractory with FLT3 mutations or potentially incorporate them into more frontline settings.